So it is a pleasure to be here. It's a pleasure to be with so many people who are interested in this topic. As far as I know, this is the first time this has been the focus of discussion in this House. As far as I know, it's the first time it's been the focus of discussion in any Parliament forum in Australia. And I've thought therefore a lot about that and what I'm going to say. And I'm going to use some notes today, which I don't normally do. Because when I'm acting as a clinical advisor, I'm very careful, as I should be, to reference back to what the facts are and to point out the limitations of those facts. But I've spent the last year getting to know a number of leaders with lived experience of mental illness and also learned about the importance of passion. And so today what I hope to do is talk about the facts behind my passion, and we'll see how we go. And the first hard fact is the fact that older people, especially older men, do die through suicide much more than the rest of the population. The next hard fact is that mostly that isn't how it's portrayed. That mostly we see graphs like this, and there seems to be a persistent avoidance of actually discussing the issue or discussing strategic approaches to addressing it. And so this is the sort of representation we mostly see when we're talking about suicide in the Australian population, which is accurate. It's just a matter of how you want to portray the issue. The subtitle of this talk might seem strange, but after thinking about it and years of talking about mental illness in older people, and hearing the response, but is it really a problem? I think even a strong advocate can sometimes think, have I got something wrong? Am I missing something? And when we look at the rates of suicide in older men, start to think, well, is it that there's not something we can do about it? Is it actually that despite everything we're taught, everything we think we know, this is part of life? But if you look at the United Kingdom, they've clearly found that it's not part of life. They have found the rates of suicide in older men have been reducing for the last 20 years. The rates of suicide in men over 75 are about half the rate they are in Australia. The rates of suicide in the oldest men have had a worrying increase in the last couple of years' reported data, but have been going down. So suicide in our oldest men does not have to be the reality of life in Australia. We do have to do something about it. So why the difference? Why do more older men die through suicide? There's no easy answers. Suicide is the end result of a complex set of risk and protective factors. Mostly they're similar to the rest of the population. Depression isn't the only cause, but it does remain the dominant one. Physical health, pain and loneliness can all be factors. But what we do know, and I think needs to be said, is it's not about euthanasia. The euthanasia debate is a really important debate for Australia to have. But it's not the debate about suicide in older people. It is time that we stop using older people to actually carry forward that debate and have the two debates separately. The only study that has actually looked at whether euthanasia is a factor in people who've died who are older through suicide found that it was a potential factor in less than 10% of cases. So, it is an important debate, but it's not what these figures are about. The other thing is, in countries where euthanasia does occur, the age distribution of where it occurs varies. It's by no means always the oldest old who die through euthanasia where it is legalised. So we need to move those two debates apart. So, why the ambivalence about talking about doing something about suicide in older people? The answer, I think, is in part that I haven't come to grips with the fierce ageism that runs in almost all of us, whether we think about it or not. It's so easy to say, well, I can't talk about what it's like to feel old, but maybe maybe some days I can. Now, I'm not talking about the days I feel bright and cheerful, but maybe it is what I should be talking about. It's part of the Australian identity to be strong, independent, athletic, particularly if you're a bloke. It's not part of the Australian identity for men to rely on others, to give a wise word rather than to do, to be valued for who we are rather than what we are or what we do. So we know media portrayals of what it means to be older are not positive, and nor it seems are the views of many of us. We don't want to die young. We could admire individual older people, but so often we feel we don't want to be old. And this emerges in the way that older people are portrayed in the media. And this is work that was done by the Australian Human Rights Commission, looking at what are the themes. And the bigger the word, the more common the theme in the media about older people. Old, forgetful, slow, frail, grumpy, sick. And from that same piece of work, we know that feeling discriminated against has an effect. Feeling worthless, sad, angry, old. And we know from work in Europe, the countries that value older people have got lower suicide rates in older people. And amongst positive messages, which are there in the media, comments come through that we wouldn't let come through regarding older people, or regarding younger people, or even middle-aged people. This is from Kate Carnell, who's done a lot of great work. And I can imagine this quote could well have been in the context of being asked, well, why is it focused on younger people rather than older people? And starting off with suicide is a tragedy at any age. Well, what was then quoted is what you see on the screen. And when I went looking for stories and trying to find some positive stories, I found this, which started off very good, but ended with this. And in case everyone can't read it, I will read it. Australia's rapidly ageing population means the numbers of such suicides can be expected to increase, Dr. Simon says. The tragedy is not that these people take their own lives. It is how they are compelled to do it in the absence of compassionate legislation, permitting medical advice and assistance, he says. How does that fit with any of our guidelines around suicide report? Could we expect saying that about anyone other than the older people in our community? And yet, where's the outrage? There is none. And there are facts that we rarely see portrayed. 3 in 4 Australians over 80 won't get dementia. Australia's facing a tsunami of older workers and volunteers. Residential aged care facilities keep improving. They're not perfect, but gee whiz, they're a lot better than they were. Residents of aged care are excluded from better access to mental health. Treatment for depression remains effective no matter what age you're at. And where is the voice of older people with mental illness and those who care about them and for them? And I just want to talk briefly about that because I think it's a key part of why this issue isn't discussed as maybe it needs to be. We are missing the voices of older people who've tried to die through suicide. And part of that is because unfortunately older people die much more often when they do try to die through suicide. They do it and die rather than survive. And it's great we have Steve Atkins with us today to provide the perspective of someone with lived experience, both consumer and carer. Because we're also missing the voices of families of older men who have died through suicide. And I'm not quite so sure why that is, but I suspect it is in part because it's so hard to reconcile the grief they feel with the messages that are out there that suicide in older people is somehow different, understandable, maybe even okay. Yet the only emotions that come to mind when I think of families I've met of older people who've died through suicide are grief and anger and sometimes guilt. I have yet to personally meet the family member who said it was a relief after death from suicide, in the way I have heard so often after death from other causes. I can still see the older man who I had to see after he had just died through suicide. And the last conversation I had with another man the day before he died from suicide. I don't want to. Most of the time I don't. But when there's a strong prompt, like preparing for today, I do. And it's not pleasant. And I wasn't a friend or family. There's nothing pleasant about dying through suicide. But policy is, and policy should be, influenced by the population's views. And there are outcomes of that. New South Wales is the only state in Australia with a plan for mental health care of older people. National mental health policy has moved slowly with regards to older people, from not mentioning them, to mentioning them, to recognising they have special needs, but not yet to action. And we look just at one part of the outcome of that, and I agree totally that services are not the entire answer to this. But I think there's a story there, and it's from the Mental Health Service in Australia report. Recurrent expenditure on mental health per capita is in general increasing on mental health, but not for older people. That is in part because the population is growing, so therefore you actually do need more expenditure to keep up with population. You can see in Australia, and so in New South Wales, there has been growth, the yellow line, but the population is still catching up with that. If we look at Medicare funded services, which is where a lot of growth has been, and access to psychological services, which is where we know there is room for so much benefit for older people, that's the little dark bar you can't really see on the right. That's where our major increase in services has been in recent years. And if you look at a smaller subsection of that, then if you're over 85, there's the opportunity to see a psychologist. It's not quite as much of a decline for state-funded community mental health services, but still it goes down. But it doesn't go down as much for inpatient care. If we don't provide the care in the community, and people don't die, but do get sick enough, they will come into hospital. And somehow we still give a lot of medication for mental health problems to older people. So what can we do? It's got to start with treating people with mental illness the same as all other older Australians. Not ignore it. Don't make special rules about access. Do ensure people with special needs have these met. To treat older people the same as everyone else with mental illness. Access to care that is effective and appropriate from services that know how to work with older people. Expecting success. And in our media coverage, especially in the reporting on suicide. And each of us confront our ageism. We need to confront the myths about ageism, about ageing. The belief that late life is a period of increasing demoralisation, depression and suffering, because all the evidence is that for most people, late life is a state of contentment and happiness. Doesn't mean all's good. Actually, older people do gain wisdom. They do find ways to keep on finding life amongst the problems. Too often, family, friends and health professionals believe that depression is normal, nothing can or should be done, and opportunities to prevent tragedy are missed. Again, a study, good study, not a nice study, from Scandinavia talking to families and GPs of people who had died through suicide who were older. And the consistent theme was they had told people that people thought nothing could be done. They didn't talk to each other, they didn't get something done, and the person died. And we can ensure we do all we can with the resources we have. The UK has got specific recommendations about how we should manage and address and take seriously when someone who's older does attempt suicide, and make sure they're seen by someone who has expertise in working with older people. We don't have that guidance. And we can start with each of us. And this is a quote from Brian Draper, Professor at University of New South Wales. Of course, adequate treatment of clinical depression is essential, and it is. It's a starting place for many people. But it's just as important to give people a reason to live. It might be a seemingly simple thing. Someone to talk to, relief from physical pain, or an air conditioner to ease breathing difficulties in a hot, humid summer. But this might make all the difference between wanting to live and wanting to die. We can all help if we believe we can. Without ignoring factors contributing to depression that increase in later life. There are reasons for depression to become more common. That doesn't mean, just because depression might seem understandable, that it cannot be helped, that it cannot be treated. And we should celebrate that most Australians do have a long and satisfying life, come what may. And so I'd actually like to finish with a quote from this week from Clive James, who at 75, a couple of years ago announced his impending death, and talked quite strongly as he can about the way he felt about his health at that stage. In fact, he was trapped in the UK. Now this is him 2 years, because of his disease, he couldn't get on a plane, couldn't come back to Australia. But this is him 2 years later. I'm now in what my friend Bruce Beresford calls the departure lounge, and the flight out is delayed. That's really what's happening. It's brighter and sharpened up because you see, even when your sight is theoretically going dim, you see things much more clearly, and you see the past more clearly, as you know from being ill. You start looking back to when you were well, to that childhood, its boundless energies. Well, I think about that all the time, and thinking about life, it gives me life. And we each must decide, should we worry?